Behind the Mask, the podcast. Behind the Mask. Behind the Mask. With Dr. William, PhD genius. Behind the Mask, Mask. Dr. William. Oh, you know the better you do. Behind the Mask, the podcast.
Hi, welcome to another episode of Behind the Mask, the podcast. Today we are super fortunate to be joined by Dr. Jack Fisher, who is an absolutely preeminent plastic surgeon. He is a world-class educator. When I say world-class, I mean he has literally traveled to the full extent of the world, teaching and educating surgeons. He has a very illustrious career. And we're just so happy to have you here. Thank you very much, Dr. Fisher, for joining us. I call him Dr. Fisher, but I've got the courage up to start using his first name, Jack, because he's such a funny, polite, humble, just beautiful human being. And I have so much respect for you that I can't get over not calling you Dr. Fisher. But on the other hand, you're just this wonderful person. And the name Jack just suits you so well. So thank you so much for coming. What we're going to talk about today is tuberous breasts. Personally, for me, I really love treating patients with tuberous breasts. It's such a rewarding surgery to perform. And when I went through, I would say, early training, I thought that these were a rare entity that I may only see 2 or 3 in my whole practice. And what I've come to learn is that it's a big, huge spectrum, and it's very, I would say, very common. We don't necessarily always have to treat it in such a, to the full extent. In some patients, it's much milder, and we can point out some maybe limitations. But in other patients that have really a bit more of a problem with their tuberous breasts, it's a full operation. So Dr. Fisher has done a lot of surgery on tuberous breasts and congenital breast problems, and I mean I've gone to your lectures over the years and seen just some of the incredible work you've done to help some of these patients that have had essentially no breast in some instances, and some huge discrepancies between the right side and the left side, for example. So I've asked Dr. Fisher to join us and share with us his knowledge on tuberous breast. So let's just start out by talking and saying, what is a tuberous breast? Why is it called a tuberous breast? Who has it? Why do you develop it? Just share with us all of that information before we jump in and talk about how to treat it.
First of all, thank you. I'm really pleased to be here, but you said a very important statement. It's far more common than people realize. And I think part of that is that it's often not diagnosed. In other words, someone might think it's just a irregularly shaped breast, but in reality, it's a tuberous breast. The one thing that's very interesting is if you look at some young women as their breasts develop, it actually looks like a tuberous breast. And the one thing I've learned over the years is just to observe these patients. And it's fascinating how some of them will totally resolve as they get through their teen years. One of the other things you brought out is a lot of patients with tuberous breasts, it can be unilateral, and they can have a congenital absence of the breast or very little breast tissue on the other side. And those are the real challenge, because trying to match it is a problem. If you have symmetrical tuberous breasts, and we'll talk about the different procedures, and I know you've had plenty of experience with it also, that's a lot easier. It's when you have asymmetry or absence on the other side, or you can see 2 totally different types of tuberous breasts. There are different categories and different classification systems looking at it, and it can be quite variable. but I have always found it to be very rewarding, especially in young women,
Yes.
because it's devastating for them.
Yeah.
Even in a bathing suit, they won't go swimming with their friends. They don't want to go to gym. They are extremely self-conscious. One of the things that's so important is first making the diagnosis, that it's not just maybe a misshapen breast, but it actually is the tuberous phenomena. And I find the simplest way for people to understand it is think what a hernia is. By definition, a hernia is a weakness in an area, and the tissue, whether it's in your groin and your gut is pushing out or some other structure, is pushing against it. In the simplest form, some of the patients, it's just a weakness of the nipple-areolar complex. And what you see is that tuberous shape as breast tissue is pushing out against it. In many of these patients, it's a relatively simple operation if they have adequate breast tissue to just do a sort of running suture and tighten up that areola, sort of like a hernia repair, and compress that area to push the breast tissue posteriorly. But in some of the patients, it's far more extensive than that. It's the whole breast has a very tubular shape. And in some, it's so extensive and the breast has such a strange shape that what I did is actually put devices called tissue expanders in there, because I not only had to correct the tuberous deformity, I needed to reshape an entire concave mound to make it look like an adult normal breast. And I found tissue expansion, what it would do is expand the skin and give me that mound shape that then I could go back in and do some of those other corrections. Some of them can be so extensive that this is what we call the inframammary fold. It's where the breast actually attaches to the abdominal tissue. It's a very important structure, very specific structure.
The most important structure of working on the breast.
Absolutely.
Yeah.
Absolutely. And so in some individuals, the problem is the location of the fold. Sometimes you can have the bottom of the areola and the fold is just maybe a centimeter or two below it. Well, even if you reshape the breast and do some of these procedures, it's still going to look very bizarre because the fold is too high. And one of the most difficult things, as you know, is lowering a fold, but lowering it properly. And the reason is you can get a very difficult deformity called a double bubble. And boy, if you want to find something difficult to fix, and we've all had to deal with it, it's what we call a double bubble. And what that means is you have the original fold, and now you've made a new fold, and you've made things even more complicated. One of the benefits of expansion, I have found, in those patients with really strange high, tight folds is to stretch out that mound. You still will have to do more surgery, but at least it allows you to establish a new fold and then do further procedures as necessary. And one of the other things we have to do is we have to fixate that fold, because if you have to put an implant in, for example, that fold could keep shifting on you as the patient ages. And one of the real difficult problems is if the fold keeps dropping along the abdominal wall. So the reason it's such complex surgery is we're dealing with a multifactorial phenomena. We're dealing with possibly the folds in the wrong place. The nipple-areolar complex could be in the wrong place. The whole breast mound has that tubular or distorted shape. So it's a challenging but very rewarding procedure, especially in the younger patient, because there's so many steps. And one of the reasons I always would tell the younger patient, it's very unlikely you're not going to have a single procedure. To really get the best result we possibly can give you, it may be stages over time where we have to correct one specific component, and then we correct another component.
I mean, that's a very, very good description of the overall problem. And because it's, I guess I was trying to think examples of, cases in surgery. Let's say you have appendicitis, and you and I both did general surgery training, so we took out our fair share of appendixes. Well, by and large, appendicitis, and maybe there's a small abscess, or maybe it's a little different location, but by and large, we're doing the same sort of operation for the most part, going in, removing the appendix, and there's little nuances like there are for everything. But tuberous breasts don't fall into that category.
Right.
I mean, it's just not one topic, and I think from a surgeon's point of view, that's what makes it interesting, is that each patient is just a totally unique puzzle. There may be something related to the surgery you did before in a different patient. It may have this aspect of this patient, but each patient kind of has this group of things that make each patient very unique, and you have to come up with a different plan for each patient. So one thing I want to talk about is what you brought up is the distance from the nipple to the fold. And so typically with tuberous breast patients, we see that very short.
Right.
Very short distance. So if you think about, if somebody wants to have a larger breast and we're going to put an implant in, we want that implant centered underneath their nipple areola. Well, if you only have a small distance between the nipple and where the fold is, if you were to put an implant in, it would probably be about a 50, 60 cc implant that would actually fit that. So you have to lower the fold and make an ample room for the pocket. If you don't, the dreaded double bubble, and I don't want to mention any names, but I certainly have become aware that there are surgeons out there that I think don't recognize a milder form of a tuberous breast, where that distance, maybe
Right.
it's not as short as what we're talking about. It's a little bit more normal, but still it's constricted, it's small. And if you don't see that and you go in and you do a primary breast augmentation, well, there's not enough room for that implant, and it's just going to go down and take skin from the abdomen, and you'll get the double bubble. And I certainly have seen quite a few of those, and as you mentioned, they're very difficult to correct, but you have to, I think the main thing is you have to prevent them by recognizing that problem there exists. So when you've talked about this spectrum where if somebody that really doesn't even hardly develop a breast, and I just want to explain a little bit about the tissue expanders, and Dr. Fisher has actually developed tissue expanders over the years. So what a tissue expander is, and we use this in all different types of reconstruction all over the body, and it's a device that goes in. It's kind of like an implant, but it's much firmer, and we place them, and then we slowly inflate them over time, and that stretches the skin, but more importantly, it actually causes a reaction in the skin to grow more skin. So you're essentially growing the breast skin, and then once that expansion has been completed, then putting an implant in to replace that expander, and you've really kind of grown a breast for the patient in
Right.
a sort of a simplistic way to do that. I personally haven't done that for breast. I've done it in a lot of other locations for reconstruction. I've done it for cancer reconstruction with tissue expanders, but I've always left that type of surgery, because that is very complicated surgery. I've always left that for people like you to be able to do that. What I frequently will do is the patients that have a milder form of tuberous breast, where I create the pocket and gain more skin and lower the fold, and then we're kind of using the implant as an expander
Right.
in a way, using it to get an immediate result, but knowing that maybe we can't get as large of an implant as a patient would like at the very first step, and then using that implant as a different way of expanding, and then perhaps 2 years later being able to put a bigger implant because we've got a little bit more room between the nipple and the fold. So take me through what you would do. Let's say one of the easier cases that you had kind of suggested where there is symmetry. None of these patients are really symmetrical, but there's more symmetry than someone having one tuberous breast, but then a breast that really didn't develop. But let's say the scenario where somebody has both tuberous breasts, they're reasonably close in size. There's going to be some things that we're going to do to try and gain more symmetry. But what would the steps you would take to somebody that had a tuberous breast, and they have that wide cleavage too? Not always, but typically they'll have that wider space. So what would sort of the steps you would take to correct that, in the operating room, and how would you counsel the patient beforehand? Just take me through your kind of, I come in and I see you and say, okay, and you say, oh, well, I don't know if you know, but you have a tuberous breast, and then take me through your consultation, how you counsel the patient, how you prepare the patient, and then your steps in the operating room, and any post-operative sort of things that you do that may be special for a tuberous breast compared to somebody who's having a just straight breast augmentation.
Sure. All good questions. Let's take a 23-year-old woman comes to your office. It's interesting, and you know this, they'll come to you for a primary augmentation, and they don't even know they have a tuberous breast.
Yes.
And you explain it to them, and they go, oh, now I understand. They have an extremely high, tight fold. The nipple, it looks like it's sitting at the bottom of the breast mound. And they just think, well, just put in an implant and increase the volume.
Yeah.
And so that's why education is critical,
Yes.
especially if you're going to have to do a staged or procedure, or as I tell them, be prepared that even if we try to do it in one stage, there's a good possibility we're going to have to do revisions at some point because this is very difficult to get everything exactly right. So you educate them, make sure they understand the difficulty. It is not just a simple question of implants. The next thing is, what size do they want to be? And you raised a good point. If you're not putting in a significantly large implant, it makes it a much easier procedure. But if they want a significant size, then you need to go and educate them specifically about the fold. Now, in some of these individuals, even though the fold is extremely high, it's not real tight. And you have a good feeling that if I just lower the fold, establish it in the right place, and put an implant in, there's a good chance a year later they're going to look fine.
Yeah.
Because that implant is going to stretch out the tight upper
That lower
fold.
part,
Yeah, it'll stretch it out and they'll look great. Sometimes they'll come back a year later and there's a hint of the old fold, but it doesn't bother them and they're perfectly happy and you just leave it. Sometimes you have to go back in and you have to score at right angles where that fold is, and it's much easier to score it once the implant has been in, because as we've talked and you mentioned, it's a natural part of the body to form a capsule around any implant or device. And once you have that established capsule, then going in and trying to release that old fold can be somewhat easier. And sometimes you have to go almost all the way to the dermis to get it to stretch out. Sometimes you put the implant back in and it works perfectly. Sometimes there's still some residual. A lot of that, as you pointed out, educating the patient. You know, I always tell patients, I use a baseball analogy. I can possibly give you a triple, but I may not be able to give you a home run. I was speaking to the British Society of Plastic Surgeons in London years ago, And I was talking about this type of surgery, and I made that analogy that I can give you a double or a triple, but not a home run.
Yeah.
And I realized no one in that audience had any idea what I was talking about. And somebody, one of the doctors, raised his hand and said, "Dr. Fisher, what are you talking about?" And I realized, don't use baseball analogies in England. So they converted it to cricket.
Yeah.
Yeah. All right. So you've got that as possibly a 1, possibly a 2 stage. The other thing is it's so important to get that fold exactly right. If you over dissect it, go too low, then there's a natural tendency of the weight of the implant to keep pushing on that new fold, and they'll come back a year later and it's an inch or two too low. And then you have to go back and raise it and do a lot of suture fixation. If somebody doesn't have much breast tissue and I've lowered the fold, I make a detailed suture fixation to make sure that I've got some reinforcement, knowing that the implant over time is going to be pushing against it, especially the combination of breast tissue, implant, weight. And I want it to push against it, stretch out the skin, but not change the location of the fold.
That's where the magic happens, right?
And
That's the difficulty.
yeah.
I want you to, please, I want this implant, please can you go and
Right.
stretch the skin out, but don't do it too much because
Right.
I don't want that, I don't want you to drop all the way down.
Right.
We just want you to know exactly how much to make a pretty breast. But that's where you're establishing the secure fold,
Right.
and you have to predict,
And you don't always get it right.
and you can't, and it's
Yeah.
impossible to always get it right.
Or if there's some, 2 breasts getting perfect symmetry. And that's why, and you raised one of the most important points, you got to educate these patients.
Yeah.
If you think you're going to come in and necessarily get one operation, which some do, it isn't always going to happen. This is probably one of the most difficult things to do. And then if you're dealing with the patient that never developed a breast on one side and has tuberous on the other, the challenge is how do you get symmetry? Now, the no breast on one side, that's going to be an inflatable device because rarely can you just put an implant
Yeah.
in these women.
You can't even get the
You
implant
can't
in.
get it in, it's so tight.
Yeah.
So that's where you do tissue expansion. And that's where it's definitely a staged procedure because what I would do is first I would make that absent breast and see exactly what its contour is. And then I would secondarily shape the tuberous breast to match it. Now, if it was a minimal tuberous breast, I would feel comfortable to try to do it all at the same time. But if it was one of these extensive tuberous breasts, I might say, 18, 19-year-old patient, let's first make this mound and then get this to match it. And I've had patients come in their 30s with very little breast tissue on one side, tuberous on the other, and you're almost dealing with them as a younger patient with congenital breasts. But you hit the nail on the head. It's all about the fold.
Yeah.
That is the hallmark of getting a good result.
I remember it hit me like a ton of bricks, and it was in breast reconstruction where I realized this is just everything is about the fold, and it's not just in breast reconstruction; it's in all the cosmetic. Anytime you work on the breast, it's all about the fold. And I don't know why I didn't realize that earlier, or perhaps it wasn't explained to me, or it was explained to me and I didn't. Sometimes people can tell you something and it just goes right over your head, and then when you're finally doing something, you're like, okay, now this is starting to add up. So if someone comes in, let me bring up this point. So you had mentioned it's this concept where the breast is sort of, as the breast is developing, it's herniating or it's pushing through the nipple and the areola. So when we do a breast lift, we could make an incision just around the areola, or we could make the inverted T or anchor, whatever you call it. And with with the incision that just goes around the areola, we tend to use that for relatively minor, at least I do, and minor movements of the nipple. Somebody
Right.
just needs a small amount. Great. If we use that incision, which everyone would prefer, and we're trying to be too aggressive with it, we're trying to really lift the breast too much just from that little incision can handle, it tends to really flatten the breast, which in this situation, flattening the nipple and the areola is exactly what we want. So I usually will combine most of my tuberous breast if they have that sort of Hershey Kiss style nipple areola, combine what I'm putting the implant in and lowering the fold, combine that with that incision so we're getting a little bit flatter.
Exactly.
And it returns us to normal, essentially.
Right. Yeah, I have found that one of the problems, because I remember early in my career, periareolar mastopexies got to be popular because the patients heard, oh, I won't have much of a scar.
Yeah.
It was way overdone. And they were trying to do really ptotic or droopy breasts with it, and they had a very bizarre shape.
Yeah.
And so I always say a periareolar mastopexy is okay, and we'll talk about what it actually is, for tuberous breasts, minimal tuberous breasts, or if you're just trying to raise the nipple-areolar complex a couple centimeters. But people were trying to raise it a tremendous distance, and it didn't look very good.
Yeah.
So what you do is you take out a strip of superficial skin called deepithelialization, and you take it out at the margin of the size of the areola you want, and then a couple centimeters beyond that, because then you're going to tighten it up. And then Dr. Dennis Hammond really developed a great suturing technique, because one of the problems that happens is if you just put in regular sutures, it'll all stretch out and go away. And what he showed us is, and I have to say, he really did a good job because I'm one of the people who trained him. So therefore, I have to take credit for anything he does.
He's one. I visited him twice. I think he's wonderful.
Dennis is brilliant.
Yeah.
Even though I can't take credit for anything he thinks of. So he does this in and out, wagon wheel suture. And what's brilliant about it is when you tighten it, it maintains the size of the areola without allowing the whole thing to stretch out. And that is really a key component when you're doing it, because it maintains the shape and the diameter, and it keeps that diaphragm that's pushing that herniated tissue or breast tissue back in place. And it's really an ideal way and a key way to do that.
And I do his suture technique because I've visited him on a couple of occasions with other groups, with other people there at the time. I think he's such a
his results, Dennis' results are just consistently outstanding.
They're beautiful.
Yeah.
So I do that, and I use the stitch that he recommends. And
Right.
I remember when I called the company to order those Gore-Tex sutures, they said, "Do you know Dr. Hammond?" And I said, "Yes, I do." And they're like, "Oh, okay."
Yeah.
So, what is the origin of a tuberous breast?
Oh, God.
Yes, I want you to answer this because I don't fully understand it.
I don't either.
And
That's
really I'm so happy to hear you say that.
Yeah, I think, and I'm just guessing, that the supportive tissue underneath that nipple-areolar complex is just totally inadequate. But that doesn't explain why I've seen 14-year-old patients with tuberous breasts, and they come back and they're 18, and the breast has grown, and it's gone. I have a series of slides of a young woman I followed over like 5 years, and it's amazing. She was so concerned about it when she was like 14, and it was significant. At 18 or 19, it was gone. Now, her breast may be tripled or quadrupled in size, but something happened when that breast tissue developed and that fullness, it just got rid of. I think what it did is it maybe acted a little bit like a tissue expander. And what it did is it stretched out the surrounding skin, and therefore it made the projection centrally less obvious and less prominent.
It makes sense. Yeah.
Yeah, but it's an interesting phenomena, and the whole mechanism. You know, years ago, Pat Maxwell and I could not figure out what an inframammary fold really was. And we were trying to identify it, and we couldn't find anything in the literature. So what we did at the time of some mastectomies with the general surgeon we worked with, we actually took out little pieces, subcutaneous tissue, immediately above and below the inframammary fold and sent it to the pathologist because they were getting their breasts removed. But just before it was totally removed, we wanted to isolate that area and some of that tissue. And we didn't even tell them what it was. The only thing they could say is there were more fibrous bands in that area where the inframammary fold was. And I think it's sort of like the way Cooper's ligaments, which we know are the ligaments, the structures inside a breast, and the average breast has maybe 20, and they kind of hold the support of it. There must be some kind of ligamentous fibrous tissue because it's such a well-established structure. And we all know what happens if you violate it. It's part of the skin.
You really do know the cause of a tuberous breast.
Thank you.
Well, you know, I really, so this is exciting for me because I love moments like this. And it's been a while since we've taken a test in college. But have you ever had a moment when you're taking a test and the question is posed to you and you actually learn what the material was, and you better understand the material that you learned because somebody posed that question, and yet you're taking an exam and you're learning at the same time. You know the feeling?
Absolutely. And actually, you've described, I've done a lot of work and taken even courses on how the human brain works.
Yeah.
And you know, there's short-term learning and there's long-term learning. You know how you walk into the kitchen and you forgot why you walked into the kitchen? You're really not getting Alzheimer's. That's a fairly common phenomena because short-term learning or thinking is very short-term. The real issue is how do you take your short-term thoughts and move them into your long-term learning? Well, you've got this bank of information in your brain that we all learned in our training, and it's what we learned repetitively over time.
It's beaten into us.
Beaten, absolutely. And then you get a short-term experience, that question that you're going, what is the point of this question? Or where is it taking me? What's the answer? And all of a sudden, that whole file of long-term learning that you got stored there comes to the surface, and it's like an epiphany, and all of a sudden you're saying to yourself, this is the meaning, or this is the reason. And again, it's the basis, all that stuff you stored up over years. And that's why so much of what we do, you know, the common term is muscle memory. It's really brain memory. And it's that stuff in the file. And if you look at a lot of innovative thoughts we have, it's just bringing together all that previous information, and then somehow we've reorganized it in our brain and we come up with a new solution. You know, one of the interesting things, if you read anything about Thomas Edison, he always would talk about most of his great ideas came to him in dreams. And it's a fascinating concept because his brain was in a different place, but he was bringing some other prior knowledge to the surface.
Well, that just happened to me because I was thinking and picturing the tissue as you were explaining and the Cooper's ligaments. Just to backtrack, the Cooper's, if we didn't have, and males have them too, if we didn't have Cooper's ligaments, our breast would be down at our knees.
Right.
And the ligaments attach through the breast tissue and work their way to the dermis, and then suspend the breast back to the chest, which are the ribs and the muscle, and support that. And the thinking that I was taught about the tuberous breast was very much in line with what you were talking about early, with that herniation phenomenon, and you can see it because the nipple and the areola are protruding. So there has to be something restrictive there. We were always taught, though, there's a restrictive, circular band. So the breast, the nipple and the areola are coming through there, and you can see it because that areola gets stretched. So
Right.
you can literally see it's big, and you could tell the journey that it was on as that breast was developing, and that nipple and the areola are coming through, and then they get to that point where they make it, and then they kind of get that look of that tuberous breast. But what I've experienced and never really understood it until you started explaining this just now, which is why I felt like I had that epiphany moment, because I know I always not only have to deal with the ring, but I think more importantly what I have to deal with are those contracted Cooper's ligaments in that lower part of the breast that's shortening that distance between the areola and the fold, and release them. And it is such a gratifying feeling. I know exactly what you know exactly what I'm talking about, where a lot of times we're doing things with tactile sense, and we're feeling, oh, there's a band here, and that's how you can find it, and then you go in and you release it, and then you get expansion of that bottom part of the breast, which we want to allow the implant to come down. So, perhaps it's we know as we love skin as plastic surgeons, and we really appreciate the
Largest organ in the body.
We appreciate it more than anyone, I would have
Right.
to say, because we deal with it all the time. But we're aware that there are patients with really poor quality skin, and then there are other patients with just amazing. They've had 5 children, and their tummy looks like they're 18.
Right.
And in the same patient, you can have somebody with 5 children, their tummy looks like they're 18, but their breasts look like they're 60. So there's various different qualities of skin throughout. We only know the Ehlers-Danlos and some of the extremes, but there's a spectrum that we don't have any diagnosis for somebody. Just, there's tissues a little bit weaker. But perhaps there's really just something physiologic with those Cooper's ligaments, that they're scarred, they're stronger, they're contracted for whatever reason. Does that any of that make sense?
Yeah.
Does that fit with what your mental image is of what the tuberous breast is?
Yeah, and that's why I think, as I said, some of these young patients, they're 13, 14, why do they look normal when they're 18? And I think it's exactly what you described. As the breast tissue enlarges and stuff, it's stretching out and lengthening the Cooper's ligaments.
Yeah.
Absolutely. You also raised another point, because we've all seen this. The patient's had 5 kids. Although she has lax skin on her abdomen, the skin doesn't look bad. And yet the breast tissue and the breast skin is very different. I've always wondered, that may be hormonal. In other words, when somebody's breastfeeding and going through all these different processes, that alone may be at least a component of why their skin sometimes extensive stria, which are the stretch marks.
Yeah.
And they're all over the place, and there isn't much on their stretched out belly. Yeah, it's hard to explain. And the dermis on the abdomen also can maintain its thickness, where on the breast, it's like tissue paper, and it's very difficult to work with.
Did you ever? So I want to tell you about it. I call sometimes when patients come to see me for a breast lift with an implant, there will be a subset of the population that have very lax Cooper's ligaments and very poor quality skin, and their breast is empty, so they want nothing more than a lift with an implant. And I feel that when I can pinch the skin and roll it in my fingers and separate it, sometimes you can even see the breast underneath.
And it has a bluish color where the stria are.
Yes. And so I will say to that patient, you are what I call a rapid re-drooper. And I will say probably within 6 months, certainly by a year, you will need a revision of your lift, because I really, we do a similar operation in a lot of different patients, and then you can get different results. And when you get a really good result, you pat yourself on the back, say, wow, I'm a really wonderful surgeon. And when you get a result that's less than satisfactory, and the patient is there tapping her foot and hand on the waist and saying, you know, I didn't pay for this. I wanted my implants up higher. I wanted a lift. And then you think, like, gee, what did I do that day? I mean, how can I have somebody who I'm very happy with their result and somebody who I'm not happy with the result, and I've done the exact same operation? And so I started to say, okay, well, I should have been able to anticipate this result because the tissue is soft. So I will then say to the patient, and I have a little presentation on my iPad, and I say, you're what I call a rapid re-drooper, and we can expect, we don't have to redo your lift and do everything again, but we're going to have to do some type of skin tightening or maybe re-excise the circumvertical pattern or something.
Absolutely. Yeah, it's sort of like the secondary facelift. The person with horrible skin, you could do a facelift on somebody, and 20 years later, you're so thrilled with yourself. You do a facelift on somebody, and a year or two, you're very disappointed. There's a well-known Israeli plastic surgeon that years ago, he just would tell his patients, part of the package is you're going to come back in a year or two, and it's part of your treatment, and I'm going to re-excise some more skin if necessary. And it's the same phenomena.
Yeah.
And you can't predict. You can a little bit, but it's frustrating.
Sometimes you're surprised.
Yeah, but
I imagine in the face it may be more difficult, would be maybe my guess, but I don't do face.
yeah, not if you're not taking out a lot. You just have to be careful that they don't look like lizards after you're done. Yeah, I mean, I've had plenty of patients that a year or two later, I'm kind of disappointed. So years ago, I was involved in the development of a suture, and it was very supportive of the long needle actually went into the pectoralis fascia, the muscle, and that gristle, and then it had hooks, and it allowed you to actually suspend the breast. The results were pretty good if it wasn't a very large breast. But in the others, even with what you thought was incredible suspension, we're stretchable creatures.
Yeah, we're still relying on the patient's tissue to hold whatever we're putting in there, the sort of weakest link in the chain phenomenon.
Yeah, unless you have a behind-the-mask clinic in outer space with your own space station, and you do your surgery in a weightless environment and keep them there.
I've never thought about that. But
That would be a great podcast.
Raised.
Yeah, come out into space with me. Our specialty, probably more than any other, we suffer from gravity. And gravity is always trying to defeat us, and probably not too many areas are as prone to the effects of gravity as the breast.
Yeah. Have you ever had somebody come in and you say, listen, you're just, in my opinion, your tissue is not strong enough for an implant?
Oh, yeah.
Yeah.
Absolutely. You know, the farther I got in my career, the more I would tell people, I don't think that you're going to be happy with this.
Yeah.
And the more I did that, the more I was happy.
Yes.
Every time I would get talked into a procedure or kind of push the parameters, afterwards I would say, I'm not sure I'm happy doing that.
Yeah.
And I learned from one of my professors at Emory a great line. You never tell a patient necessarily, because you don't want people to leave the office feeling like, well, he didn't care about me, or I wasn't a priority. you need to say something. And what I learned is, I don't think I'm the person that can accomplish what you want.
Yeah.
And then they go, well, he's thinking about me, but just telling me that he didn't think necessarily this is the right thing to do. But yeah, the farther I got along into the end of my career, the more likely I was to tell somebody, I just don't think this is a good idea. And then I was involved in an interesting case years ago where I was helping or trying to defend a plastic surgeon. He had told the patient she was not a candidate for the procedure and she would not get a result, and even documented that in the chart. And then went ahead and did it.
Went ahead and did it.
Because we all get talked into things.
Yeah.
And the patient was furious. You can't defend that. If we are the experts and we tell somebody it's not going to work, you can't say, well, the patient wanted it anyways. That has no standing.
Yeah, and that's a really good point, because that's a fairly common thing where patient that I've experienced. If I feel so, love implants. They're wonderful, but they're not for everyone. You have to use them in the right situation. But certainly, it can be very difficult to tell someone, you know what, you're not in my. And I always like to say, listen, this is just my opinion.
Right.
You need to see someone else, get their opinion. But in my opinion, an implant is not going to really be your friend.
And you have to stick to your guns, because if you don't, because here's the bottom line, we're the experts. So no matter what somebody has found online or suggested, we have to go with our judgment. And the reason we're doing that is what's in the patient's best interest.
Yeah.
That's what we're doing. We're trying to guide the patient into doing what's right for them, not to make money or do any of these other agendas, but what are you going to be happy with? And sometimes the patients are very disappointed with us and feel like, well, why won't he do this? Or why won't she do it? It's interesting, the number of women plastic surgeons. When I joined the Aesthetic Society, there were maybe 20. There are over 400 now.
Yeah.
So it's interesting how many women now are in our specialty, which is great.
Yeah. No, I mean, I think we've
Yeah,
been
things have
progressive.
changed
Yeah.
significantly. But yeah, you can't let people talk you into things.
And that would then sort of fall in line with my next question, and kind of circling back to the tuberous breast, is, you know, even there are limitations as to how far, although I think Dr. Hammond doesn't have these, but I do, as to how big an implant you can put in.
Oh, yeah.
In a tuberous breast. And so is there anything that you do to either in the operating room or in the consultation, if someone says, well, you know, I really would like a 450 cc implant, and you're thinking in your mind when you're looking at them,
3 1/4.
yeah, they may be a 325 because of this tuberous breast and it's tight, and you're going to have to work hard to be able to get the 325 in. And so what do you say to that patient?
I just tell them I don't think that's in their best interest, and particularly if I put 400s in and you're 37, you're going to be back when you're 45, and we're going to have to redo the surgery on you, because you will not be able to maintain any appropriate shape or contour. It's just not going to work.
Yeah.
And again, if a patient wants an implant that I think is going to be a disservice to them or compromise their result, I think you should get another consult.
Yeah.
So worst thing we can do is let people talk us, and we've all been there.
Yeah, of course.
And especially, remember, when I started my practice in the early 80s, a 250 was a reasonable size implant. And then all of a sudden 300 and 3 1/4, and it just kept getting bigger and bigger. And there's no question, you get to a certain size, you're increasing your potential problems.
Yeah. Well, Dr. Fisher, I really appreciate you joining us, and it's been super.
I've enjoyed this.
Super educational, I think.
Well, I've learned from you, too.
For me and for our patients, and just to discuss something that is I've had the experience where we originally discussed, where patients will come in, oh, hi, I'm here for breast augmentation. You see on the
Right.
iPad, oh, breast augmentation. You walk in the room and you talk and they take their gown off and you're like, whoa, this is not a breast augmentation. This is a very different operation. It's tuberous breast. But you know what really makes me happy is when I've had somebody come in and they're there for breast augmentation, and I open up their gown. I said, well, you have, and she goes, yeah, I have tuberous breast. And I've had
You've educated people.
I've had some feedback, and they said, yeah, I saw you made a video, and I didn't know. And that to me is heartwarming, because it can be really, we want to be honest, but it also can be difficult to tell somebody who's 22 years old, you have a congenital deformity of your breast. And, we try not to say it that way, but that's tough. When someone comes in, they want a breast augmentation, they're seeing the images of breast augmentation, and they think, well, that's what I want. I mean, it's logical, but then you come in and you have to tell them. It's nice if somebody can have at least heard that perhaps on their laptop before they go to bed, and they say like, oh, maybe this is where I fall into, and that helps to at least educate them prior to coming. So I appreciate you sharing all of your
one last
wisdom.
thing.
Yeah,
That's where
please.
digital photography has made such a difference. When you can immediately show a picture of themselves and point out on themselves, you do realize your left fold is an inch higher than your right. You do realize your nipple areolar complexes are different. Even a regular primary aug, nobody's perfectly symmetrical. Human beings are not symmetrical.
Right.
And I think that's a real good adjunct.
Yeah, definitely. Well, thank you again.
Thank you.
And thank you very much for watching. Be sure to turn on your notifications so you'll get notified when we have celebrities and icons on the podcast, on our little tiny podcast. And look at how far we've come. We now have Dr. Jack Fisher. And it's always difficult, I think, when, patients know you, but then the plastic surgery community puts you on this pedestal, and you've taught all of us so much. And then, someone's like, oh, I want to get a breast augmentation. I like Dr. Fisher's work. Let me go see him. And, they may not know they're seeing the legend. But now patients are able to have seen it on our little humble podcast. So thank you so much, Dr. Fisher.
Thank you.
And thank you very much for watching.
Behind the mask, mask, mask. Oh, you know the better you do. Behind the mask, the podcast.